Cardiac output is the amount of blood pumped by each ventricle in 1 minute. It is the product of stroke volume, the amount of blood pumped in one heartbeat, and heart rate, the number of beats in 1 minute. An increase in either stroke volume or heart rate results in increased cardiac output, and vice versa. For example, during physical exercises, the heart beats faster to put out more blood in response to higher demand of the body. It is noteworthy that the ventricles do not eject all the blood they contain in one beat. In a typical example, a ventricle is filled with about 100 milliliters of blood at the end of its load, but only 60 milliliters is ejected during contraction. This corresponds to an ejection fraction of 60%. The 100 milliliters is the end diastolic volume, or EDV. The 40 milliliters that remains in the ventricle after contraction is the end systolic volume, or ESV. The stroke volume equals EDV minus ESV and is dependent on 3 factors: contractility, preload, and afterload. Contractility refers to the force of the contraction of the heart muscle. The more forceful the contraction, the more blood it ejects. Preload is related to the end diastolic volume. Preload, by definition, is the degree of stretch of cardiac myocytes at the end of ventricular filling. But since this parameter is not readily measurable in patients, EDV is used instead. This is because the stretch level of the wall of a ventricle increases as it's filled with more and more blood. Just like a balloon, the more air it contains, the more stretched it is. According to the Frank-Starling mechanism, the greater the stretch, the greater the force of contraction. In the balloon analogy, the more inflated the balloon, the more forceful it releases air when deflated. Afterload, on the other hand, is the resistance that the ventricle must overcome to eject blood. Afterload includes 2 major components: vascular pressure. The pressure in the left ventricle must be greater than the systemic pressure for the aortic valve to open. Similarly, the pressure in the right ventricle must exceed pulmonary pressure to open the pulmonary valve. In hypertension, for example, higher vascular pressures make it more difficult for the valves to open, resulting in a reduced amount of ejected blood. Damage to the valves, such as stenosis, also presents higher resistance and leads to lower blood output.
This video will cover mean arterial pressure in 3 simple steps. Number 1. Mean arterial pressure is an average or calculated mean of the blood pressure in the arteries. It is important to point out that mean arterial pressure is not meant to be an average of the blood pressure in all blood vessels of the body, but rather an average of the blood pressure in the arteries. Blood pressure is at its highest when blood first leaves the heart, and blood pressure decreases as it continues to flow throughout the blood vessels of the body. The aorta is where blood pressure is at its highest, as this is the blood vessel that receives the blood from the left ventricle of the heart. When blood pressure is measured in a clinical setting, using a blood pressure cuff and a stethoscope, the blood pressure measurement is an estimate of the blood pressure in the aorta. A commonly asked question is, why are blood pressure measurements taken on the arm if the aorta is not located on the arm? The answer is that blood pressure measurements taken on the arm are taken on the brachial artery, which has very similar blood pressure values as the aorta. Thus, while blood pressure measurements taken on the arm are not a direct measure of blood pressure in the aorta, the brachial artery is very near the aorta, and blood pressure has not had an opportunity to decrease very much since flowing from the aorta into the brachial artery. Similarly, increases or decreases in blood pressure in the aorta result in corresponding increases and decreases in blood pressure in the brachial artery. For these reasons, blood pressure in the brachial artery has been viewed as an appropriate location to assess blood pressure in the arterial system. Number 2. Mean arterial pressure is calculated from systolic and diastolic pressure. Blood pressure is higher in the aorta when the heart contracts, as compared to when the heart is at rest. This is why a blood pressure reading has two numbers, such as 118/74. 118 is the systolic pressure, meaning the blood pressure in the brachial artery when the heart contracts, and 74 is the diastolic blood pressure, meaning the blood pressure in the brachial artery when the heart is at rest. It is also important to point out pressure has units of millimeters of mercury. However, in blood pressure readings, the units of millimeters of mercury are often not used, and the blood pressure reading is read simply as 118/74. The difference between the systolic and diastolic pressure is known as the pulse pressure. In this example of blood pressure being 118/74, the pulse pressure would be calculated by subtracting 74 from 118. 118 minus 74 equals 44. The pulse pressure is significant because formulas for calculating mean arterial pressure often include pulse pressure. A common formula for mean arterial pressure is mean arterial pressure equals pulse pressure times 1/3 plus diastolic blood pressure. Another common formula leaves out the term pulse pressure, though the calculation is still in the equation. For example, mean arterial pressure equals systolic blood pressure minus diastolic blood pressure divided by 3 plus diastolic blood pressure. In this case, the term pulse pressure is not used in the formula. However, since the formula shows diastolic blood pressure is to be subtracted from systolic pressure, the value for pulse pressure is still present in the equation, even if this value is never referred to by its formal name of pulse pressure. Since mean arterial pressure is calculating a pressure, the units used are millimeters of mercury, mmHg. In our example of taking a blood pressure reading of 118/74, we can calculate a pulse pressure of 44, which divided by 3 is 14.6, and added to 74 is 88.6, or 89 millimeters of mercury. Notice both formulas result in a mean arterial pressure of 89 millimeters of mercury. So while it is possible to see formulas for mean arterial pressure in various formats, they are still calculating the same result. Additionally, while it is common to leave off the units in a clinical blood pressure reading, millimeters of mercury are often used for mean arterial pressure. Thus, if a client has a blood pressure reading of 118/74, the mean arterial pressure is 89 millimeters of mercury. In calculating the mean of two numbers, it would be common to add the two numbers, then divide the sum of these numbers by 2. If this were done with our example of 118/74, then the calculation would be 118 plus 74 equals 192, and 192 would be divided by 2 to give a final answer of 96. However, this value is higher than the calculated mean arterial pressure of 89 millimeters of mercury. Why does the formula for mean arterial pressure result in a lower value than the standard formula for arithmetic mean? The answer lies in heart function. Blood pressure is highest in systole when the heart is contracting, and blood pressure is lowest during diastole when the heart is at rest. The heart does not spend equal amounts of time in systole as in diastole, however. When a person is in a resting state, such as sitting during a blood pressure reading, the heart spends more time in diastole than in systole. Therefore, an accurate average blood pressure would be a blood pressure that represents the diastolic blood pressure more so than the systolic blood pressure. For this reason, the formula for mean arterial pressure allows for the calculation of a mean closer to the diastolic blood pressure than the systolic blood pressure. In other words, in the case of the standard average calculation, where two numbers are added together and then divided by 2, the diastolic blood pressure is not adequately represented. This formula would only work if the heart spent exactly the same amount of time in diastole as in systole. Since the heart spends more time in diastole than in systole, the calculation for mean arterial pressure must also factor in the proportion of time spent in diastole and systole. One important consideration with this is that the formulas that are presented to calculate mean arterial pressure are formulas with the assumption that the individual was in a resting condition when the systolic and diastolic blood pressure values were obtained. During exercise, as heart rate increases, diastole shortens, which subsequently increases the amount of time the heart spends in systole. Therefore, the formulas for mean arterial pressure are only accurate when blood pressure is measured during a resting state. If a blood pressure reading is taken during exercise, these formulas for mean arterial pressure would not be accurate and should not be used. For more information on systole and diastole, see the video on the function of the heart on this channel.
In this video, we're going to have a look at capillary exchange. So capillary exchange happens at capillary beds, and this is the exchange of bulk fluids out of the capillaries. And once this fluid has exchanged out of the capillary, it's able to, via the process of diffusion, hand over the oxygen, hand over some of the nutrients that's required for the tissues, and also the tissues need to hand over to that fluid carbon dioxide and also some metabolic waste products like urea, for example. So basically we have, and you need to remember this, when the heart contracts, when that left ventricle contracts, it's pushing out oxygenated blood, which has nutrients in it, out of the left ventricle into the aorta. Now remember where this blood goes. Once it goes out via the aorta branches into all of its aortic branches, and these continue to branch like a tree. Now as these arteries, because it's leaving the heart, as they branch, they get smaller in diameter, but they become more numerous, okay? And all of these branches end up feeding all the tissues of the body. Now, every minute, that heart's going to contract and relax, contract and relax, contract and relax. Every minute this is going to happen around about 72 times, okay? So you have around about 72 beats of your heart per minute. Every contraction pushes out approximately about 70 mils of blood. So 70 mils pushing out is called your stroke volume. Every contraction pushes out 70 mils times 72 beats in a minute means that in a time span of 1 minute, your heart will push through 5 liters of blood, okay? So this is on both sides of your heart. So remember, the left-hand side of your heart deals with oxygenated blood and delivers it to the whole body. Every minute, the left-hand side of your heart will deliver 5 liters of blood to the tissues of your body. The right-hand side of your heart deals with deoxygenated blood, and therefore this blood needs to get to the lungs. And again, every minute, this side of your heart will push out 5 liters of blood. So if we just have a look at what I've drawn here on this side of the whiteboard, you'll see we've got the heart. If we have a look at the left-hand side of the heart, when it contracts, pushes blood out of the aorta branches into all of its aortic branches and then further branches into smaller arterioles. And these arterioles will then lead into capillary beds. And these capillary beds could be capillary beds of the coronary arteries, cerebrovascular capillary beds of the gastrointestinal tract, of the renal system, of the musculoskeletal system, and also the skin. Okay, these are just potential places that this blood could go through. Now remember, as it gets to the capillary bed is the site of exchange, and that's exchanging gases, oxygen and carbon dioxide, and also nutrients and waste products. Then on the other side of these capillary beds, we have veins. Okay, veins will always go back to the heart, and you can see they will come together, and these veins will get back to the right-hand side of the heart via the vena cava, whether that's the superior or the inferior vena cava. Now it's at the right-hand side of the heart. It will contract and push that deoxygenated blood where? To the lungs to get oxygenated. And again, this blood's coming through to capillary beds of the lungs. If we look at this portion, so the blood that's going to the body, every minute 5 liters. If we look at this portion, going to the lungs, every minute 5 liters. But here, this blood is partitioned to various tissues. Now, why am I bringing this up when we're talking about capillary exchange? Because when the blood's pushed out the left-hand side of the heart, it's under a particular amount of pressure. Okay, and in one of the previous videos I've spoken about blood pressure, and I spoke to you about the fact that A normal blood pressure is 120 over 80. 120 is the systolic value. So 120 is telling you that when the heart contracts under systole, this is the pressure that the blood exerts on the walls of your arteries, 120 millimeters of mercury. The bottom value, 80, is the diastolic value, and this is the amount of pressure within those arteries when the heart is relaxing. Okay? Now, saying 120 over 80 is important clinically, but to know what the mean arterial pressure is, I told you that you need to take the diastolic value and add a third of the pulse pressure. Now, if you're unsure what that means, go back to the previous video looking at blood pressure and they'll explain it all. But mean arterial pressure is 93 millimeters of mercury. That's just saying that going through the arteries of the body, the mean pressure that the blood is exerting on the walls is 93 millimeters of mercury. And as this 93 millimeters of mercury starts to move through these various branches, the pressure drops. And by the time the blood reaches the capillary beds, it's no longer 93 millimeters of mercury. By the time the blood reaches the capillary beds, the pressure of the blood inside the capillary beds is 30 millimeters of mercury, between 30 to 35. Okay? Now, what does that mean? It means that blood's going to move through these small arterioles until it gets into a capillary bed. And you know capillaries are porous. That means they have holes in them. And you can see these little holes through this capillary bed. Okay? Now, this blood's getting through, and by the time it reaches what we call, you can see one side of the capillary bed I've drawn red, the other side I've drawn in blue, because one side is the arterial end, and the other side is the venous end. Because remember, arterial blood is oxygenated. Venous blood is deoxygenated, which means that here we have that stuff coming out, and here it's no longer oxygenated. So blood's being pushed out of here, exchanging gases, so pushing out oxygen, taking in carbon dioxide, and here we now have deoxygenated blood, and this blood is ultimately leaving the tissue and going back to the heart and then to the lungs. So, as this blood's coming through, as it gets into the arterial end of the capillary, there is a blood pressure that's pushing out. And this blood pressure is, like I said, 30 millimeters of mercury. Now, remember, pressure that we measure in blood vessels is simply as the blood moves through the vessel, blood is pushing on the walls of those arteries. There's no holes in the walls of arteries. They're not porous, so blood cannot leak out. Okay? As those arteries branch out even further and get smaller in diameter, they turn into arterioles. And again, arterioles don't have holes, they don't have pores, so blood cannot be pushed out. But it's when those arterioles branch off into these smaller capillaries, that's when they have these holes and these pores, and therefore as the blood comes through and pushes on the walls, it can leak out. And so once we get to the capillaries, we now have 30 millimeters of mercury pressure pushing on the walls, and that means that this fluid, this blood fluid, is being pushed out of the capillaries. Okay? At 30 millimeters of mercury pressure. Now, the important point is this. You can see that there's little holes in the walls of the capillaries. These holes are of a particular size. Okay? Now, what is in blood? You need to remember what's inside of blood. It's not just a fluid. Inside blood, we have red blood cells. We have platelets. We have white blood cells. We also have what? Proteins. Okay? So all these substances of the blood is coming through. Now, these holes are too small to let white blood cells, red blood cells, platelets, and proteins out. Okay? They're too small. So, you remember diffusion. Remember that in diffusion, if you have a concentration difference of a substance on one side of a membrane compared to the other side of a membrane, that this concentration difference will want to balance itself out. Okay? So if I can draw it up here very quickly, if I would have a container and I was to put a membrane in between, a semi-permeable membrane. And I was to fill both sides up with water. And on one side of the membrane, I was to put some substances, some particles. And on the other side, I don't put any particles. Well, under diffusion, these particles on this side, so side A compared to side B, the particles on side A would want to diffuse from its high area of concentration towards its low area of concentration. Okay? But there's a membrane here, and this membrane will not let these particles through. So it cannot diffuse across from A to B. But there's osmosis. And osmosis is the movement of water through a semi-permeable membrane from an area of high water concentration to an area of low water concentration. What that means is basically this. These particles on side A exert a pull. Okay? They exert a pull of that water from side B to side A. So that means in order to balance out the concentration on both sides, these particles pull water towards them. Okay? What happens to the water volume on this side? It starts to rise up. Okay? So think about that in regards to the blood. We have the blood moving through, and it's exerting pressure on these walls at 30 millimeters of mercury. There's holes here so the fluid can leak out at 30 millimeters of mercury. But we have substances inside that cannot move out. These substances want to diffuse out of the vessel, but they cannot. There is a semi-permeable membrane in between. So what that means is these substances exert a pull back in. They exert a pull because there's a high concentration of particles here and a low concentration of particles here. So they actually exert a pull. Now, of all these particles, so I said red blood cells, platelets, white blood cells, proteins, which of these exert the strongest pull? The answer is the proteins. Now, the next thing is, which proteins? You should know what the most abundant protein is within the blood. It's called albumin. And this albumin protein is very important in eliciting a pull of the fluid back in. Okay? Now the strength of this pull, is 20 millimeters of mercury. Now, I want you to have a look at this. We have a push out of 30 millimeters of mercury and a pull in at 20 millimeters of mercury. When you have two pressures opposing each other, the stronger pressure will always win. What if you have two people pushing against each other and you say to one of them, push harder than the other person? That person's going to win. Okay? They're exerting more force. So, if you have a look at these two, which one's exerting more force? The 30 millimeters of mercury pushing out. That overpowers the 20 millimeters of mercury by, what's the difference? 10 millimeters of mercury. Okay? What that means is, at the arterial end of a capillary, stuff gets pushed out. Okay? There's a pull back in, but overall, stuff gets pushed out. Now, of the stuff that gets pushed out, this is fluid. This is a bulk push of blood fluid coming out. And in this fluid, it has gases because they're small enough to get through in the fluid. And it has substances like glucose. They're small enough to get through these gaps as well. And then this fluid can exchange with the tissues. Now, as we move across from the arterial end, because remember, blood's moving through like this. It's coming through, pushing out. As we move from the arterial end to the venous end, I want you to think about what happens to this pressure. If you had a hose and you were to connect that hose to a tap, and you turn that tap on at a particular pressure. So you turn it on, let's say you turned it on halfway. And you had a look at the hose, let's say the hose is 10 meters in length. You look at the other end of the hose and water's squirting out that end at a particular pressure. Okay. Let's say you were to now put holes in that hose. So let's say every meter for the 10 meter hose, you put a hole. Hole, hole, hole. And you have it turned on at halfway, and you have a look at what's happening. At those holes, you see water squirting out, right? Now let's say you have a look at the hole that's closest to the tap. the water's going to be squirting out of that hole at a particular pressure, at a particular height. As we move down, what do you think? So just think about what's going to happen to the pressure of that water pushing out of those holes. Is the pressure going to increase or decrease? Is the water going to push out at a higher distance or less? Well, think about it. Hose is turned on. Water's pushing out at a particular height closest to, but because that water's leaving, the pressure drops distal to that. And then the next one squirts out, but it's a little less. And then the next one drops, a little less. So the pressure decreases as you move down the hose because these holes are reducing the pressure as we're moving through. That's what happens in capillaries. So as we move from the arterial end, stuff's getting pushed out, so the pressure in here drops. And that means at the venous end, the pressure drops enough that it ends up being a push out of 15 millimeters of mercury. Now, these substances, such as, and I'm just going to draw the albumin, is continually moving through. So it's still on this side of the venous end of the capillary. Okay? So these substances are moving through, so these proteins are still exerting a pull of the fluid back in. And this pull is still around about 20 millimeters of mercury. So have a look now. If you were to measure the pressures against each other, which one now wins? Well, 15 out, 20 in, the pull in now wins. The difference, 5 millimeters of mercury. So what that means is, at the arterial end, we have a bulk flow or a net flow of fluid being pushed out. And then when we get to the venous end, we have a net flow of fluid being pulled back in. And the reason why this is important is because the fluid that's on this end is handing over oxygen and substances like glucose, and then it's continuing past. And then on this end, the tissue is handing it carbon dioxide and waste. And why is that perfect? Because this is where the fluid gets pulled back in and can get taken back to the heart. Perfect. Perfect, perfect, perfect. Now, the push out and the pull in have names which you need to know. Okay? So, the push out, remember I've drawn it in red. So the push out is called the hydrostatic pressure. And basically it's blood pressure, right? Because it's the pressure of the blood being pushed in the walls of the arterial end of the capillary. Okay, the pull in, which I drew in blue, so I'm just going to draw the blue arrow here. The pull in is called colloid osmotic pressure. And I told you it's the pull of the proteins in the blood pulling that fluid back in. Now, let's just think clinically for 1 second. What if we were to increase the size of these gaps in the capillaries? Let's say they're now big enough for proteins to move out. So that means that as the blood comes through, 30 millimeters of mercury pressure pushing out, not just fluid comes out, but also the proteins come out as well. If the proteins leave the capillaries, is there any pull back in? No. So that means we have all this bulk flow out, including proteins, and there's no proteins to move to the venous end. So there's no pull back in, which means fluid just continues to accumulate outside the capillaries in an area called the interstitium, meaning between the tissues. This is edema. So when you see a patient who has fluid build up at the bottom of their legs, or at the periphery, this is edema. And it can be due to, one of the reasons, a widened gap between the endothelial cells of your capillaries. Think about inflammation. Inflammation is just injury or damage occurring to vascularized tissue. Everyone's had some form of inflammatory response. Let's say you've cut your hand. What happens? You've got the 4 cardinal signs of inflammation. You've got the redness, you've got the swelling, you've got the heat, and you've got the pain. Okay, these have been known for thousands of years. But what's one of those that we need to remember? Swelling. So you cut yourself, you always notice swelling at the site. Why? Because when you damage cells of your skin, these cells explode their guts, and inside there's histamine. And histamine is a chemical that creates larger gaps in your capillaries. Why? Why would we want this? Because if I were to cut myself, whatever cut me, let's say it was a nail, what if there was bacteria on that nail? I now have bacteria in my interstitium, okay? How am I supposed to attack it and kill it if all my white blood cells are in my capillaries? Well, histamine opens up the gates, and my white blood cells can come out and attack the bacteria, kill it off. But what that also means is fluid comes out. But this is good as well because the fluid sort of washes it away and dilutes it. Okay? Now, you may think that of all the fluid, under normal situations, of all the fluid that gets pushed out on the arterial side, that it all gets pulled back in. That's not the case. There is a small percentage of this fluid that once it gets pushed out, it cannot get pulled back in. Now, this is enough, even though it's a fraction of the fluid, it's enough that at the end of the day, if we could not find a way to pull that fluid back in, if we could not pull that fluid back in, our blood pressure would drop enough that we'll die at the end of one day. So it means that of the fluid that can't get pulled back in, we do have a mechanism. We need to get that fluid back. How do we get it back? The lymphatic system. So we have lymphatic vessels as well around our tissues. And the lymphatic vessels help bring back that lost fluid from capillary exchange and drops it back into our venous supply. So I hope that this made sense looking at capillary exchange.